Venous and Lymphatic Disorders, Clinical Mastery Quiz. Let's dive right in.
Question 1. What is the primary structural mechanism preventing deep venous backward flow? Is it A, arterial collateral circuits, B, bicuspid endothelial valves, C, capillary smooth muscle, or D, tunica media elastic tissues? Lock in your answer. It's B. You see, venous return from our lower limbs relies heavily on the calf muscle pump and a network of bicuspid endothelial valves. These thin-walled valves are perfectly oriented to allow unidirectional forward flow toward the heart whenever your muscles contract. Then, they literally snap shut during relaxation to prevent gravity from pulling that blood backward.
Moving right to question 2, we have a 42-year-old female presenting with tortuous dilated calf veins greater than 3 millimeters. What's her CIEP clinical stage? A, C1, B, C2, C, C3, or D, C4? The correct answer is B, C2. Let's break down exactly why.
Looking at the clinical arm of the CIAP classification system, it starts at C0 with absolutely zero visible signs of venous disease. C1 covers the tiny stuff, like telangiectasias under 3 millimeters. But right here at C2, and this is a massive exam pearl, 3 millimeters is the strict defining threshold for true varicose veins. Moving up, C3 introduces edema, C4 brings skin changes like pigmentation, C5 is a healed ulcer, and C6 is an active venous ulcer.
Question 3. What is the gold standard non-invasive imaging to evaluate chronic venous insufficiency? A, venography, B, duplex ultrasound, C, MRV, or D, air plethysmography? And the answer is B, duplex ultrasound. This is the absolute premier choice because it combines B-mode structural imaging, letting you visually see the vein, with color Doppler flow assessment so you can actually watch the blood moving. It allows us to directly spot clots and measure the exact duration of backward flow. If reversed flow lasts longer than half a second in superficial veins or over a full second in deep veins, valvular insufficiency is definitely confirmed.
Question 4. What is the mechanism driving skin hyperpigmentation in a 50-year-old male with a medial malleolus ulcer? A, atypical melanocytes, B, venous hypertension and hemosiderin, C, iron overload, or D, fungal infection? The answer is B. Chronic valvular incompetence creates this persistent high venous pressure in the lower leg. That immense pressure physically stretches out the capillary pores, forcing red blood cells to leak right out into the dermis. As those cells break down, macrophages degrade the hemoglobin, leaving behind permanent brown hemosiderin deposits that literally stain the skin from the inside out.
Question 5. What are the 3 classic pathophysiologic categories of Virchow's triad? Is it A, thrombocytopenia, stenosis, and hypotension? B, endothelial injury, stasis, and hypercoagulation? C, hyperlipidemia, vasoconstriction, and tachycardia? Or D, vitamin K deficiency, malnutrition, and walking? You guessed it, the answer is B.
Virchow's triad is the absolute cornerstone for understanding VTE risk, and it's built on 3 pillars. First up, stasis. Think about immobility, like being stuck in bed or trapped on a long-haul flight. Second, endothelial injury. This happens when physical trauma or surgery damages the actual vessel wall. And third, hypercoagulability. These are conditions that make your blood abnormally prone to clotting, like an active malignancy or certain genetic mutations.
Speaking of genetics, question 6. What is the most common inherited thrombophilia mutation in Caucasians causing DVT risk? A, antithrombin 3, B, factor V Leiden, C, protein S, or D, prothrombin G2021A? The answer is B, factor V Leiden. Present in up to 5% of Caucasians, this mutation physically alters the factor V molecule so it can no longer be cleaved and turned off by activated protein C. That resistance leads to runaway thrombin generation and a seriously high risk for clotting.
Question 7. We have a 28-year-old female, 4 days post-op, presenting with severe leg swelling and a pale milk-white appearance. What's the diagnosis? A, phlegmasia alba dolens, B, phlegmasia ceruleus dolens, C, superficial thrombophlebitis, or D, acute arterial embolus? Lock it in, it's A, phlegmasia alba dolens. Historically called milk leg, this is a severe iliofemoral DVT with complete deep venous occlusion. The superficial veins are still open, just enough to prevent cyanosis, but the massive edema compresses the dermal capillaries, giving the leg that striking pale white look.
Question 8. What happens with unmanaged progression of that previous condition, causing a cyanotic, blue, painful leg with a real risk of gangrene? A, Burgers, B. Phlegmasia cerulea dolens, C. Raynaud's, or D. Milroy's? The answer is B. Phlegmasia cerulea dolens. This is a true limb-threatening emergency. Total venous outflow is blocked. Massive fluid buildup skyrockets your compartment pressure until arterial inflow is choked off completely, producing intense blue cyanosis, blisters, and an imminent risk of venous gangrene if you don't clear that clot fast.
Question 9. A 22-year-old female presents with a painful erythematous cord-like structure on her medial thigh. What's the diagnosis and management? A. DVT, treated with warfarin. B. Superficial thrombophlebitis, treated with NSAIDs and warm compresses. C. Lymphangitis needing a fasciotomy. Or D. Necrotizing fasciitis requiring debridement. The correct answer is B.
So here's the critical difference. Superficial thrombophlebitis is fundamentally benign because it's localized purely to the surface network. We manage it with simple supportive care, warm packs, NSAIDs, and getting the patient moving. Contrast that with a deep venous thrombosis, which is a highly aggressive pathology, demanding immediate systemic anticoagulation to stop a life-threatening clot from spreading.
Question 10. A 35-year-old female has an isolated left common iliac DVT, compressed by the overlying right common iliac artery. What syndrome is this? A. Nutcracker. B. May-Thurner. C. Paget-Schroeder. Or D. Thoracic outlet. The answer is B. May-Thurner syndrome. This is a specific anatomic variant where the left common iliac vein is literally sandwiched between the right common iliac artery and the spine. The continuous beating of that artery against the vein causes webs and scarring inside, creating local stasis and a super high incidence of left-sided clots.
Question 11. A 22-year-old weightlifter gets right arm swelling and a subclavian axillary DVT. What is the specific term for this effort-induced thrombosis? A. May-Thurner. B. Paget-Schroeder. C. Budd-Chiari. Or D. Superior vena cava. And the answer is B. Paget-Schroeder syndrome. Clinically, we call this effort thrombosis. It happens from repetitive mechanical compression of the subclavian vein right between the clavicle and the first rib. You'll classically see this in young, healthy athletes doing intense, repetitive overhead motions, like pitching or heavy weightlifting. Question 12. What is the principal goal of systemic anticoagulation for an acute DVT? A. Dissolve the clot. B. Arrest propagation and prevent PE. C. Widen arteries. Or D. Increase WBC. The answer is B. Here is a huge exam pearl. Anticoagulants do not actually dissolve the clot. They just hit pause on the coagulation cascade to stop the thrombus from growing or breaking off into the lungs. They stabilize the situation, buying time so your body's native tissue plasminogen activator system can slowly break the clot down on its own over the coming weeks.
Question 13. You have a proximal DVT patient with an absolute contraindication to anticoagulation. What device prevents a pulmonary embolism? A. ePTFE stent. B. IVC filter. C. Coronary stent. Or D. TIPS. The correct choice is B. An IVC filter. When you've got a known clot but the patient has high bleeding risks, you place an inferior vena cava filter percutaneously. It acts like a specialized mechanical mesh trap, catching any large emboli breaking off from the legs before they can travel up to the right heart and lungs. Question 14. A 16-year-old female presents with bilateral lower extremity non-pitting edema shortly after menarche. What is her primary lymphedema classification? A. Congenital. B. Praecox. C. Tarda. Or D. Secondary. The answer is B. These primary classifications are totally dependent on age. Lymphedema congenita starts at birth up to age 2. Lymphedema praecox kicks in between ages 2 and 35. And it's crucial to remember that praecox makes up roughly 80% of all primary cases, usually showing up right around adolescent menarche. Finally, lymphedema tarda is any onset after age 35. Question 15. What is the most common global cause of secondary lymphedema? A. Axillary dissection. B. Lymphatic filariasis. C. Radiation. Or D. Cellulitis. The answer is B. While developed nations mostly see secondary lymphedema from cancer surgeries or radiation, on a global scale, the #1 cause is lymphatic filariasis. It's a mosquito-borne parasitic infection that physically damages the lymphatic vessels, leading to severe chronic obstruction and elephantiasis. And our final question, question 16.
The inability to pinch a skin fold at the base of the second toe to diagnose lymphedema is called what? A. Homan sign, B. Stemmer's sign, C. Carvalho's sign, or D. Trousseau's sign. The answer is B.
Stemmer's sign is a highly specific physical exam finding. It is definitively positive when you literally cannot pinch and lift the skin on the top of the second toe. That incredible stiffness is directly caused by intense cutaneous fibrosis and proteinaceous fluid buildup. It really makes you wonder, with so many overlapping vascular and lymphatic signs out there, how many of these subtle clues mimic each other every day in a chaotic emergency room?